My name is Lori Heisey, and I am one of the co-research directors of the STRIVE Consortium. Today we have, I think, a really interesting and exciting talk from a colleague here at the London School of Hygiene and Tropical Medicine, Michelle Remme, and she's a health economist and has worked quite a bit on the issues of financing, both here in London with STRIVE, and then before that with the Dutch government and within the United Nations system. So I think she has been, I know she has been really fundamental to getting our working group going on development synergies and co-financing, and we're really happy to have her here and to further our collective knowledge about the potentials for co-financing. So I'm going to turn it over to Michelle.
Thank you very much for tuning in for this Learning Lab. Well, since Lori has introduced me, I'll just go straight into the presentation, which I've given a bit of an ambitious title here, with breaking down financing silos, the potential of co-financing. I will focus on illustrating the concept of co-financing and its economic benefits from an efficiency perspective. And just to point out that most of this, or everything actually that I'll be covering, is in this article that was recently published in AIDS in January of this year. And it has been very much a collaborative piece of work between colleagues at the school, so myself, Anna Vassel, and Charlotte Watts, and colleagues at UNDP, so Brian Lutz and Jorge Luna. And just to point out as well that this article should be available as open access very soon, if it's not yet. And there's also a related editorial piece that you might want to look at if you're interested. So the background to this paper and this piece of work is the growing recognition of the importance of structural drivers for HIV service uptake and retention, as well as in shaping the environment in which HIV risk occurs. And linked to this is the growing importance of structural interventions to tackle these drivers. But by their very nature, these interventions have multiple health and development objectives and therefore outcomes. Now, in the context of shrinking HIV funding and a general resource scarcity in countries with high HIV burdens and multiple development challenges, structural interventions with multiple outcomes are actually quite an opportunity and could represent a very good return on investment. This has been recognized by the UNAIDS Strategic Investment Framework, which highlights that HIV and development synergies are smart investments, even when you're only taking the HIV perspective. And this is also reflected in other agendas, such as the Social Determinants of Health agenda and health promotion efforts, where it's very much recognized that investments in other sectors are critical for the success of such responses. Now, I just wanted to pull out the investment framework here just to be a bit clear about what type of interventions we're talking about. So I'm sure many of you know this investment framework quite well, but just to come back to the categories, in the center you have the basic program activities, which are the traditional conventional HIV interventions. So you have key population programs, PMTCT, condom promotion, behavior change, treatment and care, and male circumcision. And these are basically interventions that are expected to have direct impacts on, by preventing HIV infections and keeping people alive and on treatment. And the critical enabler category are those other interventions or activities that are meant to increase or enhance the efficiency and effectiveness of these basic programs. So, for example, community mobilization or stigma reduction would enhance the effect of condom promotion, for example, to actually generate the HIV benefits. And at the bottom there, you have those development synergies, which are essentially interventions in other sectors, so probably not in the typical realm of HIV programs, which have direct impacts on HIV prevention and treatment outcomes. And here we have social protection, education, legal reform, gender equality, and so on. And so I'll be focusing mostly on these development synergies down there. These development synergies essentially are acknowledged to be very important in the HIV response, but despite that, there is this risk that because we don't allocate resources from this bigger societal perspective, that actually they could be undervalued and potentially underfinanced as a result of a silo mentality and when making such budgeting decisions. The HIV sector could be reluctant to take on such development synergies, which is already coming up a bit in broader discussions, and that is likely because they perceive that there's a low HIV-specific cost effectiveness and that most of the benefits are being accrued in other sectors rather than in the more traditional HIV sector. We think this is partly a result of a methodological approach that we take when we think of value for money, where on the one hand we compare the HIV value only to the full program costs, because you need that full investment in order to generate that HIV benefit. But by basically looking only at one benefit, we might be not doing justice to these type of interventions. And so even if we do demonstrate that certain structural interventions are effective for the HIV response, they might be less likely to be considered during budgeting exercises and even less likely to be prioritized and actually funded. So to illustrate this a bit better, we'll take the example of the Zomba cash transfer trial that was conducted in Malawi. And the intervention was essentially a cash transfer to keep girls in school. It was about $10 a month that was provided to in and out of school girls. Part of it was conditional. Well, there was a conditional arm and there was a smaller unconditional arm. 30% went directly to the girl. And for this investment, in just 18 months, the trial found a number of outcomes. So we have here a 35% reduction in school dropout rate, a 40% reduction in early marriages, 76% reduction in HSV2 risk, 30% reduction in teen pregnancies, and a 64% reduction in HIV risk. And this, essentially, if you would look at this from a societal perspective, you would compare the cost to these benefits, and the benefits would probably seem to outweigh, well, given the remarkable benefits, it's likely that this would be considered a socially efficient intervention that would be worth funding. But typically, funding decisions are not really made from that perspective. And so if you would take the HIV perspective, which is the one we're coming from here, is we would look at the 64% reduction in HIV risk, and we would compare that to the full investment. And that's what the authors of the paper did, and they estimated a cost per HIV infection averted of between $5,000 and $12,500. This would not compare very favorably to other HIV interventions, and because of that, it would probably not be in the basket of interventions that the HIV budget holders are considering when they're making resource allocation and prioritization decisions. Now, if all sectors would do the same, if all sectors would only look at their specific outcomes, so if education would look at this 35% reduction in dropout rate and the full investment, they might come to the same conclusion that it's not cost effective for them and therefore decide not to fund it. And in the end, if all sectors do that, this intervention with all these potential benefits would not be funded, and you would have this loss to society, essentially, or what we economists like to call welfare loss. And that would be an inefficient outcome from a resource allocation perspective. The assumption there is that the money would not be used to do anything else. Another way to illustrate the inefficiency is that, which is probably more likely, is that the money would probably be used in those sectors to do other interventions in the sectors. But that still might come out inefficient, because if, for example, the education sector would want to say we could get the same reduction in dropout rates by doing something else that only would cost us half the price, and then the gender sector might say the same, and the reproductive health sector might say the same, and the HIV sector would also get the same outcome for half the price. In the end, you would get the same outcomes, but you would pay double the price for them, or double the investment. So that would be that inefficiency there. In our paper, what we propose is that there may be an alternative to each sector deciding whether to fund such an intervention in isolation or within their own silos. And instead, HIV resources could be used to co-finance structural interventions with other benefiting sectors. In that case, the value for HIV money of structural interventions could then be assessed based on the HIV sector's specific contribution. So the objectives we had in our paper were to explore to what extent maintaining the status quo, so the use of HIV-focused cost-effectiveness decision rules, could lead to suboptimal HIV financing decisions. And once if we were to find that co-financing would make sense, then to explore whether there may be different ways in which the HIV sector could consider co-financing these interventions. We modeled 3 financing approaches. The first one was a cross-sectoral cost-benefit analysis, which takes a societal perspective and then compares the long-term benefits across sectors to the costs of the intervention. And this is essentially sort of the gold standard from an economic perspective to really see whether such an intervention or such a program is worth financing, if it's from a side, if it's an efficient investment. Then we took the 2 approaches that are likely, that may be applied in actual decision making. So there's the silo approach, which is the current approach, where sectors use their own thresholds or decision rules to decide whether to finance the intervention. And the co-financing approach is where instead sectors would agree to co-finance the intervention, and they would use their own thresholds to determine how much they would contribute. In this last scenario, in the co-financing scenario, the question then comes up as to how much should each sector pay if they do decide to co-finance. And since we're taking the HIV perspective, we're focusing more on how much should HIV pay. And we have these 3 options that we modeled. The first one is sort of a maximum amount. So this is, for the HIV sector, it would be worth funding an intervention up to the point for which it is considered cost-effective or HIV cost-effective. So we used the WHO threshold as that cutoff point, where WHO suggests, basically the guidelines from WHO are that an intervention that can avert a disability-adjusted life year at a cost that is below a country's GDP per capita is considered cost-effective. And that has the most solid sort of normative underpinning in human capital theory and tends to be the one that's used, at least in academia. We're not entirely sure how much it's used in decision-making, but it is what we use when we say whether something is cost-effective or not. And so using that threshold, we say HIV would pay up to that amount in relation to the costs of the intervention. But that might not be necessary. So if other sectors are willing to fund more, then actually the HIV sector might only have to fund the residual program costs that would not be funded by other, as long as it is below this cost-effectiveness threshold of GDP per capita. And lastly, there's the fair share option, where we would look at the cost-benefit analysis and then allocate basically costs based on the benefits. So the HIV benefits in the total would be used to apportion the cost that the HIV sector would take on. Again, provided that it's below the maximum threshold. So here are a bit of the methods. I won't go into too much detail, but if there are any questions, we can definitely discuss them later. We very much drew from the study of the Zomba trial, so the Baird et al. At 2012, published in The Lancet. We used their unit costs to estimate the program costs, and we used their impacts or their effectiveness outcomes to estimate the absolute impact for each outcome of interest. Now, because this cost-effectiveness threshold in the health sector is defined based on DALYs, we had to translate these impact figures into DALYs averted. So we used standard DALY formula to do that, and estimates from the disease control program too, which again, I probably should not go into too much detail here. For the cost-benefit analysis, what we did was we monetized DALYs based on GDP per capita to be consistent, and we modeled the other benefits based on a cost-benefit analysis of conditional cash transfer schemes, where they estimated basically how much dollars benefit you would get for every dollar you invested in such a program. And here they considered the higher earnings that would come out from such an investment for women and the reduced child mortality. In terms of co-financing calculations, and I'll show you in the actual example here in more detail, is that we estimated the willingness to pay for each health outcome as the total DALYs averted times this threshold of GDP per capita, which was therefore the price each sector is willing to pay per outcome. And for the education outcomes, we estimated it as the total impact times the highest cost-effectiveness ratio that we found in the literature. because the education sector does not seem to have a normative threshold like we have in the health sector. And we conducted a number of sensitivity analyses to explore this further and to see the effect of uncertainty in the figures we're using, essentially. So the results are here. The results of the cross-sectoral cost-benefit analysis show us, on the one, so we start with the intervention costs. So you have the implementation costs and the actual savings you might get from averting future treatment, leading to a net intervention cost of about $75,000. Then the net intervention benefits are the HIV infections averted and how they translate into DALYs averted. And then all these other long-term benefits to education and health, which I mentioned earlier. So the increased earnings and reduced child mortality. And that's about $385,000. So when you add those up, you have a net intervention benefit of $480,000 about. So the benefit cost ratio here is 6.4. which is very high. It means for every dollar invested, you get a $6.4 return. And you have a net benefit of over $400,000. So from the financing decision that is likely to come out of this is that this looks like quite an interesting investment and is worth funding. Now, for the other two scenarios that we modeled, you'll see the outcomes, the results here. I'll just take you through the HIV line so that you can maybe see in a bit more detail what we did. So for the HIV outcomes, the number of infections averted, we estimated, based on the study by Baird and colleagues, that the Zomba trial had an impact of 6 HIV infections averted. We translated those infections averted into DALYs. So for every infection, I think it was about 15 DALYs averted. So here it's 94 DALYs averted. And the willingness to pay per unit, so per DALY averted, was the GDP per capita of Malawi, where the trial was done. So that was 339 in 2009. And so we just multiplied the total DALYs averted times this willingness to pay to get the total actual willingness to pay of the HIV budget holder for such a program, which is over 30,000, so about $32,000. When we look at that in relation to the total program costs, which were $110,000, that would represent about 29%. Now, we do the same for all the other outcomes, which you see down there. And what you see at the end is that if each of these sectors, so the HIV, we're considering HIV to be a separate sector, the education sector, the section of reproductive health and mental health sectors, so let's just say the non-HIV health sectors, none of them would come up to 100% of the program costs. So in a silo approach, the most you would get would be 60% of the program, which would be the sum of the sexual and reproductive health and mental health willingness to pay, and that would not mean that the program would not be funded by anyone. So then in the co-financing scenario, on the other hand, where these sectors would come together and consider co-financing the intervention, you would get more than the actual program costs. So we would have 146% of program costs, and the program would be funded. So the potential inefficiency that would have come out of missing out on these benefits would have been prevented through this co-financing approach. Now, another way to illustrate this, and I'm grateful to our colleague Brian for his slides here, is the problem essentially is this silo approach, where you have the program cost, and each sector has a willingness to pay that's actually below the program cost. So the program is not funded, even though it has these benefits. The co-financing scenario is this one, where actually they would all come together, and the sum of their willingness to pay is greater than the cost of the program, and the program is funded. Now, once the co-financing outcome seems desirable, then the next step is to figure out how much each sector would pay, which is likely to lead to quite some bargaining and other challenges. But what we modeled here were the three options I mentioned earlier. So the maximum that the HIV sector would be willing to pay would be its GDP per capita threshold. So that would represent the 29% of intervention costs, as illustrated above. And that is represents a cost per HIV DALY averted of GDP per capita, because that's how we've defined it. The minimum it would be willing to spend is the residual from other sectors. And since the sum of the other sectors is actually greater than the program cost, the HIV sector might not have to pay anything. And therefore, the intervention would be cost-saving from an HIV perspective. And finally, the fair share approach, where it would pay its share of the benefits, is about 25%. and that would be a cost per HIV daily averted of 297. So that is well below the GDP per capita threshold. And in all of these cases, with the co-financing, the intervention is highly HIV cost-effective in Malawi. Again, another way of illustrating that is you have this minimum here where HIV essentially pays the residual, but there is no residual, so the other sectors are covering the cost of the program, and the maximum here is HIV pays its maximum willingness to pay, the red box, and any combination of the other sectors paying the difference. In both of these scenarios, the program is funded. The limitations of the approach is that it is a theoretical framework and a theoretical approach to optimize synergies across sectors. But such intersectoral coordination has been tried and tends to be hampered by other institutional incentives. And so there's a need definitely to better understand these barriers and how they could be overcome for this type of co-financing to be a reality. And the other issue, more on the technical side of the methods we use, is that cost-effectiveness thresholds may not be commonly used in resource allocation, especially in low and middle income countries, but they are also there's also need for more research to understand what budget holders in governments and among donors are actually willing to pay for different outcomes if it's not based on these thresholds. The issue, though, I mean, it is an issue, and it isn't in the sense that these thresholds are used as proxies of willingness to pay, and the concept would still be applicable if you would use other measures of willingness to pay, if we have some more real-life estimates. One more concern that is raised often in relation to the WHO threshold in particular, is that these thresholds do not actually represent or reflect budget constraints and affordability. So the issue of affordability is one that comes up often, and WHO thresholds are considered to be too permissive, and because at the end everything ends up being cost-effective, or usually most interventions turn out to be cost-effective based on this criterion, and therefore it's not very useful for prioritization when you end up with still more interventions than you would actually be able to fund realistically. So what we tried to do was to model very roughly what this would represent in Malawi on a national level to see if it diverts substantially or if it really does not seem to be affordable at all. What we did is we took the Zomba trial and assumed that it would reach all secondary school girls that live below the poverty line, which was about 53,000 in Malawi, and we modeled that through here. So you see at the national scale how much it would cost in $1 million based on the co-financing shares that we estimated based on the trial example. And so the national scale would be $3.2 million per year to implement, and the HIV sector would pay about $930,000 of that. Now, in relative contributions, if you compare this to the national HIV budget and also donor disbursements in these different sectors, it doesn't seem to be too unaffordable. I mean, it represents about 1.2% of the HIV budget, 0.9% of the health budget, and 0.6% of the education national budget. And in those national budgets, we're not really considering fully the donor disbursements. This is, again, just an illustration. It's not a full affordability analysis, but it's just to maybe a starting point to that part of the discussion. And so in conclusion, what we conclude is that with a silo approach, certain structural interventions with potential could be underfinanced or go unfunded. And just to highlight that this is not exclusively an issue for the HIV response, but it is more generally for health and the social determinants of health issues, but also horizontal health system strengthening investments, which have broader benefits across the health sector, but are often very hard to get people to vertical programs to fund. But also other development programs which have cross-sectoral solutions, such as nutrition, gender, and just more broader poverty reduction as well. Co-financing could provide an opportunity to realize development synergies, but it will require cross-sectoral coordination and negotiation mechanisms, which may also have their own transaction costs that we would need to consider. And a caveat here is that, as I mentioned before, cost-effectiveness is only one criterion at best in resource allocation, and which is very much a political process and has other considerations such as equity, acceptability, affordability, and also the programs that you would not be able to implement because you would implement these programs. But despite this, only considering HIV outcomes in an economic evaluation of structural interventions would provide incomplete evidence for policymakers and could therefore lead to undesirable decisions from an HIV as well as a societal perspective. So I'm going to end there. Very much look forward to your questions, comments, and suggestions, as this is still in its early days, and we're keen to explore how to take the work forward and its feasibility and operational challenges.
Great. Thanks a lot, Michelle. That was incredibly clear of a very complex topic. You were talking, Michelle, about willingness to pay and how these other things like percentage of GDP, per capita GDP, are sort of proxies for willingness to pay. For us non-economists, could you say a little bit about how willingness to pay is normally calculated, and if we were going to try to get a more accurate or realistic willingness to pay from, let's say, a set of finance ministers, given the various things that they're juggling, how would you go about doing that?
Thanks, Laurie. Yes, so willingness to pay that we use here is willingness to pay from a budget holder or sort of policymaker's perspective, and which is why we took the normative approach. But actually, what is probably the preferred approach in economic evaluation or cost-benefit analysis is to estimate willingness to pay by actually eliciting it from people, so from figuring out what is society's willingness to pay for various outcomes. And so that would consist of contingent valuation methods, where you would actually ask, for example, patients, if it's for a health intervention in various areas, different questions and trying to gauge where is the cutoff point. You could directly ask, what would you be willing to pay for this? There are a number of issues with that people, there's a number of biases that can come out of that people are afraid that they will actually be asked to pay. So they might then, underestimate or understate their willingness to pay. So this has been used a bit more in the environmental sector to figure out what people would be willing to pay for a cleaner environment and so on. Not so much in the health sector, and I think even less in the HIV world. So that would be one approach. Alternatively, which I think would be interesting, would be actually to use that approach, but more from a policymaker's perspective. So really to go and ask policymakers using some of those methods what they are willing to pay for different outcomes, and trying to explore how that willingness to pay varies with other factors. So other possibly equity, what kind of other factors are, where are the trade-offs with equity, for example, or with just maximizing the size of their budget in order to increase their power, because I think there are a lot of political economy aspects within this and criteria that influence these decision makers' willingness to pay. So that would be the type of approach, I think, and methods that we could try to use to elicit this, and from a different ministry's perspective, but also Ministry of Finance. But a lot of decisions are actually not, they don't seem to really be made based on these normative thresholds. So I think there's really a need for a better understanding of what are they based on then, and are some of these economic evaluation data used to a certain extent, and at what point in the decision-making process are they used, etc. I hope that answers your question.
So I had a question, and I did wonder, Michelle, if in your experience, given your experience with the UN system and with national governments, if you had any thoughts about how this could steps towards getting this up into more of a sort of application situation.
Thanks, Annie. I think to a certain extent it is not brand new. It is something that is partially being done, maybe not explicitly from with this sort of theoretical background, but I think there are examples of co-financing even in low and middle income countries and in the HIV world. I previously worked in Malawi, and for example, there the Global Fund financing was used to pilot and actually partly fund the rollout of a social cash transfer scheme, which was initially really focused on targeting labor-constrained households with the objective of actually reaching households with orphans and vulnerable children, mostly, which is why the Global Fund was interested in it, and UNICEF, together with the Global Fund and the National AIDS Commission, were really leading on that. And after that, it was rolled out, and other donors came in and put more funds into it. So I think it has partially been happening. Even in the health sector, HIV funds have been used to fund broader health system type of interventions. So top-ups, for example, for salaries of health workers across the board, not just health workers working on HIV programs. So there is somewhere to start from, and it has been done. It's maybe not as explicitly as we would think, but I think I'd be very interested for us to look back at those and maybe document a bit more of such examples and understand why they worked in some settings and what might be barriers in others. I think what helped in these examples, for example, was that at that point, the HIV sector had quite substantial financing, and now in the context where funding is going down, I think the HIV budget holders will be less keen to invest their scarcer resources in such interventions because they might be worried that they will not see the HIV benefits as directly as they would for investing in treatment, for example. So I think that is the risk, and that's probably why now it's more than ever it's important to try to explore what type of mechanisms could be put in place to create incentives for such collaboration and coordination.
I mean, generally, how does the willingness to pay consider the national priorities or the government priorities?
Yeah, and another question from Wanda. So this is Jerry. I just wanted to hear from Michelle in terms of the context, especially in the developing countries and because we've been giving the example of Malawi, my only concern is Malawi is a heavily donor sort of dependent country. And in this context, like even in Tanzania, we have our current budget, about 40% coming from donor funding. But also currently in Tanzania, there's a discussion about bringing other players, especially in the health sector, for example, private players, so public-private sort of partnerships. So I don't know what are the implications for that in terms of the framework that you are developing.
Excellent question. I think the willingness to pay that we're using here, I think one of the main probably criticisms of the sort of the WHO thresholds as well is, as I was saying, that they don't reflect necessarily the budget constraints, and with that probably the other priorities in the country. But the framework is really just a proof of concept, and the ways of taking various country priorities into account would probably be done based on how you involve the different actors. So, if the right sectors and the right budget holders are part of the discussion, you would probably have to take all these different country priorities into account. The donor dependence and so on, yes, obviously we're taking very much the perspective that donors are, that these decisions are being made by ministries or governments at least, but probably the donors would have the same type of decision-making process as a resource allocation, where they do have some kind of cutoff point when they decide, how much they're willing to contribute to what. So it does just bring in more actors, I think, the donor dependence issue and the public-private partnership issue as well, because you need to be involving the private sector. But all in all, I think the framework should be applicable to all. It's really just the idea of bringing the right actors and the right sectors together for all the different priorities to be taken into account at the same time rather than separately, to avoid the inefficiency that would come with that.